Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Shawn Martin, CEO of the American Academy of Family Physicians, about primary care pulse check, transitioning in a time of uncertainty. Let's get started. Hello, Dr. Dan. How are you?
I'm great, Faisel. How are you today?
I am doing wonderful. And look who we've got. We've got Shawn Martin. Shawn, it's so good to see you.
Good to see you guys. How are you guys doing?
Doing well. Doing well. Thank you so much for joining us today.
Thanks for the opportunity. What a great way to spend a Monday, right?
Gosh, these days, I love all that you're doing with your call to actions constantly. Every time we see you, it's like, hey, I'm doing this call to action to do this for primary care, wherever we see you. And I love this. Me and Dr. Dan were going over your recent op-ed with your call to action for investing in primary care. Let's just get started. With what inspired you to write it?
Yeah, the idea came, just kind of reading the tea leaves. Irrespective of how the election would have gone, we got to a point where it was going to be a new administration. The general feeling around Washington, D.C. was there was going to be this kind of turnover of senior staff, and whether Vice President Harris won, or of course, President-elect Trump won. And I started thinking through, what if we just wrote them a letter and just said, look, we're just going to write this letter and put it out in the space and try to start a conversation about this kind of new beginning with new people, with a kind of renewed focus on primary care and what it would take to make primary care high performing and more accessible to more Americans. And so we wrote it.
You outlined these three critical issues facing primary care. Number one, the system's failure to meet the population health needs. Two, the financial strain on practices in general. And then three, the lack of protection for the primary care doctors, physicians. Love for you to kind of dive deeper into these. What do you think the root cause is of a lot of this, and why are they so urgent right now?
Yeah, I think the last time I was with you guys, I think we talked about the fact that nothing happens by accident, right? Our current state of healthcare in the United States is the output of, multiple decisions over multiple decades. But I think the truth that we face in 2024 and going forward is we have a sicker, aging population. And I think what happens in health policy circles is we tend to focus on the aging part and not the sicker part. We know that, onset of disease is happening in younger and younger people. They're carrying chronic diseases longer in their life. They are comorbid longer in their life. And that creates downward pressure because of utilization of services, and they need more from the healthcare system longer. So we have become less focused on health and more focused on taking care of people that have disease. And the cost of that leads to the second thing. It costs us a lot of money to do that. So because we didn't prioritize primary care in the 50s, 60s, and 70s, we are paying the price for that, if you will, today in, Medicare. And because we didn't prioritize primary care in the 70s, 80s, and 90s, we are paying the price for that in the commercial health insurance market, because 30s and 40-year-olds are actually sicker as a cohort of people than their parents were. And so we just have this repeat cycle of disease onset that's, happening in the country. I think it all happens because we didn't invest in primary care. The country has never really committed itself to a primary healthcare system, not just primary care physicians, but a primary healthcare system. We continue to put financial barriers between people and primary care. And as a result, they don't use primary care to the extent they should, and we have promulgation of disease and illness that eventually manifests itself in, the most expensive healthcare entity that we have, which is a hospital. And that's not a knock on hospitals. It's just, people end up there, and that's the most expensive end of the spectrum, and that's where too many people are going because of their disease state.
I think a statistic in your op-ed was, and I think I've got this right, 35% of all care is provided by primary care, but only 3 to 5% of the healthcare dollar goes to primary care. So And we do know that primary care is the only specialty that lowers cost and improves outcomes over time. So if you got the chance to talk to whoever the next head of Health and Human Services is going to be, whoever that might be, what would be your message for them taking that all into account?
Yeah, I think there's a couple things, right? Like, I mean, I think the time value of money is really interesting when you think about primary care, because I'm not talking about spending 25% of our total healthcare spend on primary care. We're really talking about something in like the 10 to 15% range. But, that investment, oddly enough would be, 50, 60, 70%, maybe 100% more than what we're investing today. So just a significant amount of money flowing through the primary care function. But I think the other thing that I would say to them is I think it's two parts. I think you have to invest cash, literally cash, into the primary care function to support the physicians, the clinicians, the teams, the infrastructure that is needed to provide robust, comprehensive, and connected primary care in 2024. The other thing you have to do is you have to remove all the financial barriers for individuals and families to access primary care. So we have become so premium sensitive in the United States, which has led to higher and higher deductibles, which has led to fewer and fewer encounters with primary care. So our healthcare system underinvests in the people we're asking to do the hard work and puts all of these financial barriers between an individual and primary care. It is a disincentive to go see a primary care physician because it's cash on the barrel.
I mean, it doesn't make a lot of sense to put a copay between an individual and their primary care provider.
Yeah, and so you see concepts like direct primary care, which is a model I love, I think is really innovative, but it's becoming more and more popular because patients are saying, look, if I'm going to pay cash anyway, I'll pay cash, very intimate one-on-one relationship, with this physician that I'm going to have for a number of years, which, to me should be a warning flag to the rest of the healthcare system. Like I think the DPC model is saying, look at this alternative over here, and the rest of the healthcare system is kind of turning its nose up at it. But I think the principles are a good message for everybody else.
For the medical students and like the primary care residents, they're passionate about having this value-based care, high quality primary care way of practicing medicine. Like, how do you propose that we can at least start addressing like a lot of the systemic? I mean, is it, besides the transition to value-based care, like what do you think the roles are with the alternative payment models with getting us there?
Yeah, I think, I started this work a long time ago. For me, we're on the third generation of primary care innovation, in kind of what I call the post, HMO world, right? So we had the medical home, and I think the medical home was an important conversation starter. I think it moved us forward on kind of what it means to be patient-centered and reimagining the role of primary care in the delivery system. Then I think we've right now we sit, in the ACO world. And I think the ACO world is, this weird mix of value-based care, upside, downside risk. I still don't think it's the ultimate answer, but I think it's moving us closer to what I do think is the ultimate answer, which is, kind of the third generation of, just a really, really pure population-based prospective payment that's, providing the financial support and resources to pay for how we want primary care to be delivered. It becomes very agnostic to modality, to sites of care. It becomes very patient-centered because physicians become 100% empowered to take care of the patient in the best way for that patient. It's the true financial model to support what we think about a patient-centered care. You guys have heard this speech before because I've seen you in rooms when I've given it, but I think COVID really taught me a lesson. I think we were very patient-centered, right? We threw that word around a lot pre-COVID. And then COVID happened. And I started thinking about the fact that we were asking like 80-year-olds to go to a doctor's office in the middle of a pandemic. That is not very patient-centered. In fact, that's probably the opposite of patient-centered. So we ramped up telemedicine and audio care and other types of things and really, I think, changed for a lot of people, what it meant to really center the patient in kind of the workflow or work stream, and the payment models don't support that. So I think purely prospective population-based payment is where we need to go, and I think everybody can play in that game.
There have been a lot of attempts to change payment models, But it seems like those innovations are happening on a 2-year cycle, a 3-year cycle. I mean, we think about Medicare Advantage, and Medicare Advantage really came into being in 1997. And I don't know how many different times they have changed the reimbursement model there. And it makes it very difficult when we ask the doctors, the providers, the healthcare systems to staff up for these models, but then we decide we're paying too much and cut back on it. That makes it pretty difficult for people.
It's like whiplash, right? Like, I mean, you're just kind of constantly in a state of being pulled back and forth. Our data internally at the AAFP suggests that there's a tipping point. If you get a certain number of payers and a certain number of patients into an aligned value-based model, then the practice will practice that way even for the patients that aren't in a model. And I think that's what we have to keep moving forward towards. I mean, it's a competitive marketplace. I don't see a scenario where the competitive marketplace suddenly, aligns around one model, in the near future. But I think we're trying to push them to align around some principles. If you guys all will just kind of do these things, then practices will have more predictability on how they approach value-based care. But I think a lot of it is, maybe I'm just getting older and slower, but I just keep coming back. I think there's just one or two things that really make a difference. And I think the first one is this, the cash flows up front. You get the money flowing through a population-based payment faster with more consistency. And then the second thing is you stop measuring activity. Like, you stop asking family physicians, primary care physicians, and practices to report on all the things they're doing all day, and you start having them report on the outcomes they're able to achieve higher upstream. And I don't want this to be an MA commercial, and I don't want people to misconstrue this statement, but I think MA, has moved that conversation forward, because I think there's more of an upstream evaluation of performance in the Medicare Advantage program than there are probably in some others.
Well, we need it. We need it. All right now. More of us are. We meet. We're in the business of meeting doctors, primary care doctors, and there's a growing number of us who are just like, we don't want to get integrated more within the systems. Like, this is like where I've never felt it so much, where it's palpable, where there's a big chunk of us just trying to, okay, you know what? We don't want to integrate into the larger systems. Like, we want to kind of break free of it, even though we do need to get integrated. Like, we need to be the central pillar of that system, but there's like this pull back and forth, like what are some steps that we can take for those of us who are like, we know we got to go, we got to be a central pillar, but it's just that barrier. It's so hard to cross through. Like, what are some steps that we can take to help integrate primary care back into the center?
I think some of it is just language we use to talk about primary care. And the concept of integration is like a really weird word to me, because it's such a business word, right? Like, it's not a patient word. Like, nothing about the word integration makes me think that, like, you're providing compassionate, comprehensive care to your patients, right? Like, so I think, what I think is kind of key is for primary care physicians and groups to get aligned, for them to align with, their payers and insurance companies on some set of common goals, get aligned around the approach to payment. I think horizontal integration of primary care physicians is probably going to happen. It's a complicated world, right? Like, the systems you need, the staffing you need, the primary care team, community health workers, you probably need some economy of scale to really do that for covered populations, especially if you're inside a risk or a capitated environment. But that's different than vertical integration, where everything's kind of getting bought up, and pulled into one vertical, and losing autonomy across those physicians. So I don't know the ultimate answer here. We see some early data of physicians leaving hospital and health systems and kind of going back out into other types of practice arrangements. We see people, I'm going to use the word aggregate instead of integrate, aggregating primary care practices to create, scale for them to be independent but aggregated, right? So they're independent practice sites out there, but they're kind of aggregated around some core functions so that they can benefit from different types of services. But I don't know, Faisel and Dan, I think anything that restores autonomy to the individual physicians and practices is a good thing, and anything that takes away from that is a bad thing. So that would be kind of my litmus test, I guess.
Because then they don't care about the workload, right? As long as they're the right, like they have some control over the financial issues. I mean, and as long as they're feeling fulfilled, I mean, that's like the cure to burnout, right? So when we meet residents who are like, hey, I knew I was going to be a primary care doctor. I knew I was going to be a family doctor a long, long time ago, right? Like we don't need to do any convincing. We've got them already. But for those who are like, hey, that was actually, that's what I'd like to do. What are some incentives for them or some changes in the training? Like I'm very excited. I've been excited about all the rise of the community-based training programs. I mean, now there's like 150, 160, maybe even more now, probably close to 200 of them. But what are some of the incentives or changes that we could do in training that would help make family medicine, primary care more appealing?
I have a belief that, most people that have a calling to go into medicine, I mean, this is something that, bubbles up from inside, right? Like it's, that is always, I want to go take care of people and families and communities. And, whether that's through primary care or surgery, but it's this calling, it's a passion and compassion for fellow humans. And you want to, deliver on that through the art and science of medicine. There's not anybody that's like, I want to go check boxes on an EHR all day and fill out prior auth, paperwork like that. I mean, maybe there's a few, don't get me wrong, but I mean, that's not really motivating people to, pursue a career of service to fellow humans. So I think, we've got to, in the training years, almost like reorient them with that calling that they experienced, 8 years earlier when they set out on this journey to become a physician. And I think, a lot of our teaching programs are, under the financial strains of their host institutions, or, residents are trying to, meet their number for continuity clinic and, different types of pressures that kind of take away from that. So what we talk a lot about is getting them out of the residency clinics and out in the community and out into rural communities where they see a different type of primary care. So they see both the good and bad of like what's possible. But the other thing, this is one of my favorite things I tell medical students and residents all the time, like family medicine is not a single career. So if you become a family physician, you're not going to do the same thing every day for the next 35 years of your career. You guys are like exhibit A and B in that, right? So you might do continuity clinic, you might do adult care, you might do hospice, you might do sports medicine, you might work in an emergency department part-time, you may do some palliative care, and you may do all those things over the course of your career, either in isolation from the other things or in combination with the other things. And if you really want to take care of people and take care of communities, like family medicine starts to really become an obvious choice for people that are really drawn to that type of service. And I think we just have to tell that story in ways. And it's not me telling that story, it's you guys telling a story. And you guys are masterful storytellers about those opportunities. And look, if you want to, run a podcast, apparently it's possible.
Yeah.
You think? It turned out to be something to do during COVID for a while, but it turned out to last past COVID. Yep. So one of the things I've been thinking about recently, and I know there's a lot of discussion about women's healthcare in the news, but we have a lot of communities without access to OB care. And traditionally, I know all family medicine doctors are trained to do OB, but most of us, including me, don't wind up doing OB. What are the answers there? How do we support that? Because it seems like there's nearly half the population that we're not giving them the care they need.
Yeah, I think this is a great point. I don't have an answer, so I'm going to share some perspectives, but I think this is an all of us problem, with our colleagues at ACOG, the obstetricians and gynecologists, and the nurse midwives, to be honest with you. I think there's the three disciplines need to, really think about an all of us solution to this problem across the country. And we are. I mean, we started having those conversations and thinking about it. And, I really appreciate, the March of Dimes kind of leading this research and this study. And I really appreciate them including family medicine in their workforce projections for the first time ever. Like, I think that changed the dynamic of the conversation on a go forward basis. Look, we've got to create meaningful training opportunities. We've got to create opportunities for residents to engage in both surgical and non-surgical FMOB training and fellowship opportunities. But we also have to create a supportive practice environment. And, most of the time, I'm guessing for you, Dan, if you no longer do OB, like the practice environment made it almost impossible for you to maintain that service. Either you didn't have OB backup, OB-GYN backup, the liability became an issue, the payment, problems persisted, the hospital said, no, we can't afford to do this anymore. A lot of times it just comes down to the practice environment creates so many disincentives for family physicians to stay in. And I don't know what to do here. It feels like one of those, you ever play that game where you flip the cards over and then you have to find the two dinosaurs or whatever? I feel like we need to flip cards over a lot faster and find the two that go together, because I think the answer exists. There's some policy levers that we can pull to create these opportunities, and I just don't know what they are. And that's just it's weird to come on and say you don't know the answer, but I just don't know yet. But I think it's out there. But I do think family medicine is a huge part of that answer.
I see that with the direct primary care practices. I mean, not that they're doing OB and GYN, but they're just able to practice more like the way we were trained. I remember in residency, just to put in a referral, to do a referral, it was a process that we were doing so much of it, and as it's one of the things that we hear regularly from students and the residents is about these career options in direct primary care, and I'd love to hear a little bit more about how you see direct primary care fitting into this broader landscape with all of this reform is happening. So, DPC, and there's a lot of great work happening with data collection and sharing and all of that. But for the students, if you had a message for the students who are considering direct primary care for whatever reason, what would you advise them about navigating within this model?
Yeah, I mean, I think, direct primary care is the purest form of that kind of ideal state that we spoke about earlier, right? What called you to primary care to begin with. I'm neutral. I think it takes a lot of solutions. Let me just say this up front. I think it takes a lot of different practice types, a lot of different solutions to meet the primary care needs of the country. I think direct primary care is really emerging as one of those, top tier solutions. And I think I'm very proud of the work we've done at the AAFP to nurture and foster and help it mature to this point. And I think its moment is arriving, right? I think it's there. I think getting students and residents, kind of interested in this model, it's a different approach than anything they've ever seen. I mean, they grow up in the academic, clinical basis. So, when you go out there, and oftentimes it's, one physician, a lot of them don't even have staff. It's just kind of you. And you strip away all the, noise and frivolous activity that's associated with kind of the modern practice of family medicine. And you just start taking care of patients on a relationship basis, on a clinical basis. And I think now that probably what's different now than 8 years ago is there's places for them to go into as an entry level. So they can go into an existing direct primary care practice and kind of, build their own clientele and learn and, almost not quite an apprenticeship, but you know what I mean? There's not the pressure to just go out and have to build a business overnight. You can, be nurtured through the model until you're ready to do that. I don't know where it goes. I think it's fascinating. I think it's a fascinating model, but we'll see. I don't think it displaces large, large aggregated primary care groups in every community. I think it's going to, grow and kind of flourish alongside some of the more traditional settings. And I think that's great. I think the more opportunities there are for family physicians to go find a place to practice that meets their needs is a good thing.
I'm with you. We're with you. So let's shift gears a little bit here because I'd love to hear your thoughts about the impact of this new administration and how it might affect primary care with Donald Trump coming back to office.
Thanks for raising the question. I think, obviously I would start with the obvious. Every election, particularly presidential elections, create disruption. I mean, elections by design are disruptive. That's kind of the nature of our system. So I think there will be a pivot or a shift, from the approach that the Biden administration has had on a number of fronts. I think the interesting thing for us to think through here at the Academy, we have some experience with President-elect Trump. I mean, he was in office for 4 years. We understand the healthcare priorities of him and the people that likely will be around him. So it's not starting from scratch with, trying to figure out how we're going to move forward. I think there are some things that align, with our values. I think there's a, renewed focus on rural healthcare that will be important. I think there's an importance on making, sure that we're addressing the fundamental healthcare needs of people and, opioid use disorders, reduction in deaths of despair and addiction. I think those types of things are obviously places that their priorities align with our priorities. And I think we're going to meet that moment. That's an opportunity for us to be an active engager and supporter in advancing those policy objectives in the country. And then there's other places that, we kind of put in the unknowns. I don't know exactly how to think around their approaches to Medicare Advantage, their approaches to the commercial insurance market and the marketplaces and Medicaid. Medicaid's, weird because of the shared responsibility between the federal and state government. Medicaid expansion has, been very beneficial to many states that were very supportive of the president-elect. So it'll be interesting to see how they think about reforms in that space because of the kind of growth of the program in states that are very supportive of the president-elect. So, it's my obligation and our obligation at the Academy to represent the needs and interests of our members, irrespective of who sits in what chair. And that's the approach we're going to take. But, I always remind our team, like we have core values. Those values are instilled in us as an organization and as a membership, and we will advance those, irrespective of political climate, and we'll do our very best, to represent the, professional needs of our members every day and to protect their ability to do what they went into medicine to do, which is to take care of their patients and communities.
That kind of goes in line with what you said here in the op-ed, that you say that prioritizing primary care is essential not just for the health outcomes alone, but for the overall economy. Like investing on primary care, it has long-term benefits for, just the broader economy of the country.
Yeah, I think, healthcare policy and economic policy and, the so-called kitchen table issues, they're all the same, right? I think most families, have they have housing security, food security, health security. Those are things that every family, irrespective of where you are on the income spectrum in this country, all families focus on those things, right? They want the same things and the same outcomes. And I don't know that you can have economic prosperity if you don't have healthcare prosperity. Healthcare can consume an enormous amount of money for companies and governments and individuals, but it's also the leading cause of bankruptcy. So, you see in data the opposite side of what healthcare security looks like to far too many families in this country. And I just don't think that's a partisan issue. I think people feel that every day. And whether you're a physician or a business owner or a government official, you see that is not in alignment, that people do not have healthcare security for the most part in this country because, mainly because of the cost.
You're talking about that, and I'm thinking about Steve Jobs with all of his billions of dollars money was not able to buy health at the end of the day. And so encouraging a strong healthcare system is almost beyond the ability to say what it's worth financially, right? No matter how much money you have, you're still at risk in healthcare problems. And ultimately, you're going to be facing those. The stronger the system we have, and the stronger the system we have based on primary care, is going to help everyone, regardless of their ability to pay.
Well, I agree with that completely. And it's almost, primary care for me is, giving everybody access to comprehensive and continuous primary care. It's almost like clean water, right? It just helps them live a healthier life, staves off the onset of disease for as long as possible. Disease will happen. I mean, you guys, I'm lectured to physicians on this. Like, I mean, but what you want, you want disease to set in at an age beyond 40, right? Or beyond 35. Like, can we just keep people healthier longer? And that health has ripple effects through the economy and, more productivity, less absenteeism. There's just all kinds of things. And I think there's always opportunity around primary care because primary care is just almost a nonpartisan issue, right? Like everybody can wrap their head around the importance of primary care.
And you'd never have been talking about like, hey, we got to put 20 cents of the dollar, 30 cents of the dollar. We're not talking anything. Like you said, I mean, it's still a pretty small chunk of the total pie.
30 cents, Faisel, don't get me wrong. Like if they offered it, maybe we'll start at 12.
In closing, especially for the students. I mean, right now, the students, even early doctors, they're early career doctors, they're passionate about primary care, but they're feeling increasingly disillusioned by the system. How do you stay hopeful? How do these people stay hopeful and inspired when the road ahead right now seems kind of tough?
I mean, boy, this is tough. I will use this talking point. I think I might have used it in that op-ed. I can't remember. I've read the obituary of family medicine and primary care multiple times in my life. But yet, here we are. We are still, the foundation, at least from a visits perspective, of the American healthcare system. It's proven. It's been proven all over the world, but it's been proven in the United States that when you have continuous access to comprehensive primary care, you live longer, you spend less money on your overall healthcare over the course of your life, you have higher, well-being scores as far as your ability to live the life you want to live. And I go back, I take very seriously my responsibility to deliver to them the world that they described in their medical school interview. When they wanted to take care of people and families and do that in an equitable, just way, as long as I have the opportunity, we're going to try to build that world for them. There's no direction but forward for me on those quests until somebody tells me we can't go forward anymore, right? Like we're just going to keep moving forward. But I really think it's important to connect learners to that vision of what they want to be and building that healthcare system for them. It's what patients want too. I mean, no patient is like, I love it when I go see Dr. Dan and he stares at the computer for 30 minutes. Like, nobody likes that. If there's two people in the exam room and they both hate that, let's build a better world for them. Let's let everybody be happy in that encounter. And we can do that. It's not beyond our capabilities.
Shawn Martin, thank you so much for coming back on again.
Thank you.
What are your thoughts on primary care pulse check, transitioning in a time of uncertainty? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.